Hey everybody, and welcome to another video here at Whiteboard Doctor. We appreciate you checking it out. Today we have a topic that is very relevant clinically. It's something that I think about, utilize, and discuss almost every single day when I'm working clinically. And that is the cardiac output and cardiac index. We're going to work to explain these two concepts clearly, break them down into both their mathematical equations as well as their different components. We're going to talk about stroke volume, preload, afterload, contractility, Frank Starling curves, Anrep effects, the components of contractility. We'll talk about heart rate, beats per minute, when that heart rate is actually too fast, and then we'll summarize it with a few equations at the end. It shouldn't be too long of a video, but it should be one that hopefully you leave with a much fuller understanding of these two concepts. So great video for everybody interested, but also specifically for those in healthcare, whether it be nurses, students, residents, interns, physicians, nurse practitioners, physician assistant, respiratory therapists. Keep the list going. So no further ado, we're going to break for a quick 60-second introduction. Don't go anywhere though, we're going to dive into things right after. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer, none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So the cardiac output to start. At its most kind of basic definition, the cardiac output is the amount of blood pumped out of the heart every minute, right? The output of the heart, cardiac output, output of the heart. And that makes sense from a definition standpoint. Equation-wise, though, mathematically, the way this is calculated is the cardiac output, CO, is the stroke volume times the heart rate. We have a picture of a heart over here. If we're thinking about the amount of blood pumped out of this heart every minute, the components of that is going to be the stroke volume, how much actual blood is being pumped out in every beat, which is known as the stroke volume, multiplied by the number of times the heart pumps per minute, or the heart rate. And that conceptually makes sense to give you the cardiac output, the amount that the heart is pumping out every single minute, which is how much blood gets pumped out in a single heartbeat times the number of beats in each minute. And a normal cardiac output for your everyday person is about 5 to 6 liters of blood per minute. Think about that for a second. That's 5 or 6 liters of blood that's pumped out of our hearts every single minute. That's a huge amount, and your heart does that the entirety of your life. It's an extremely impressive muscle. Interestingly, when they studied this, specifically in those who are young, healthy, this can increase as much as 5 times with peak exercise. So those that are young and healthy can actually increase their cardiac output to almost 30 liters per minute with extreme exercise. 30 liters per minute of blood that your heart is pumping around your body every single minute with extreme exercise. That's, again, incredibly impressive, a physiologic feat if you really think about it. So that's your cardiac output. Well, how does that relate to your cardiac index? Well, simply the cardiac index is actually just the cardiac output, how much your heart is pumping around your body every single minute, divided by a person's body surface area. So the cardiac index is really just kind of a way to standardize the cardiac output, because everybody requires a slightly different amount of cardiac output, right? People who have a large body surface area, you're 6'7", muscular, you're going to require more blood to be pumped around your body per minute. Those that are smaller, 4'9", thin of build, they're going to require less blood being pumped around. So the cardiac index just takes that into account by dividing your cardiac output by the body surface area. And the cardiac index, at least clinically, is what we pay attention to more when we're thinking about these, because again, larger people are going to need more cardiac output, smaller people are going to need less cardiac output, and the cardiac index standardizes those values. And a normal cardiac index is written down here about 2.5 to 4 liters per minute per meter squared, which is just the body surface area portion of that equation, right? Meter squared. So cardiac index is nothing fancy other than a way just to kind of standardize the amount of cardiac output people need based on the size of that person. All right? So if we're going to break it down, the cardiac output we said was stroke volume times heart rate. Starting with stroke volume, what exactly is the stroke volume? Well, the stroke volume, abbreviated SV, is, and I'm going to explain what these are, the end diastolic volume minus the end systolic volume. To understand this phrase, we need to understand diastole and systole, right? So I got this little video clip of a heart pumping. Let's see if this works. Moment of truth. There it is. The heart is pumping. Excellent. So diastole and systole are the two different cycles, and I want you to focus over here while I'm talking about what these are. So diastole is when the atrium, which is this component, there's 4 heart chambers. There's 2 atrium, 1, 2, and 2 ventricles, 1, 2. Right atrium, right ventricle, left atrium, left ventricle. All right, and the atrium pump blood into the ventricles. So what diastole is when this atrium is contracting, see, contracting, 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 and pumping blood through this valve here into the ventricle. And if you look, you actually see when the atria contracts and squeezes, the ventricle relaxes or moves outwards. So moving out, moving out, moving out, that is diastole, and that's when blood is filling the ventricle. That is compared to systole, and systole is when the ventricle is squeezing in. We see it going in, 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 in. And that is when the ventricle is pumping blood out of the ventricle to the rest of the body. That's systole. So let's go back to the definition. End diastolic volume, right, which we said the end diastolic volume, if I draw my own heart over here, the end diastolic volume, we have the right atrium, right ventricle, left atrium, left ventricle. The end diastolic volume is when there's the most blood in the ventricle, right? Because diastole is when the atrium is squeezing blood into the ventricle and the ventricle is relaxing. So end diastole, the ventricle is going to be big. End systole is after the ventricle's contracted and squeezed all that blood to circulate it around the body. This is going to be end systole. So end systolic volume, end diastolic volume. So the diastolic volume is when the ventricle is full of blood. The systolic volume is when the ventricle is contracted and there's only a little blood left. And the difference between those two is the stroke volume. That makes sense, right? Because how much blood is pumped out of the ventricle, right? The ventricle here, blood pumped out of the ventricle is going to be how much blood initially filled the ventricle minus how much blood is still left even after it's squeezed. And that is the stroke volume. So hopefully that makes sense. If it doesn't, let us know in the comments and we're happy to clarify in the comments. But that is what the stroke volume is. It's the amount of volume that was pumped out of the ventricle. So the end diastolic volume when the ventricle is completely full minus the end systolic volume, which is what blood is left after the ventricle has squeezed. And it's determined by 3 main things. And we're going to explain each one of these things. The first is the preload. Second is the afterload. And the third is contractility, also known as inotropy. Excuse us. Starting with the preload. What is preload? Well, preload is the volume in the left ventricle. We could even erase left because it could be, right or left, but it's the volume in the ventricle at the end of diastole. So if we go back to our video, and remember we said end diastole is that when the ventricle is completely full of blood. See, it's relaxing and filling, relaxing and filling, relaxing and filling. and that's the end diastolic volume. That is the preload. And it makes sense that the stroke volume would be dependent partially on this, right? Because we said the stroke volume is the end diastolic volume minus the systolic volume. So if the end diastolic volume is larger, right, and end diastolic volume is preload, if it's larger, then stroke volume will be higher as well, right? And that's true for many things, but there are a few exceptions to that, which we'll go over. If we look at this graphically, which is over here. So if we look at this graphically, we notice a few things. We have the end diastolic volume, right, also known as the preload, the amount of blood in the ventricle when it is completely full, and then we have the stroke volume. Both of these are in milliliters. And we see the curve, and we see as the preload increases, the stroke volume increases as well. Normal is here. This is a normal end diastolic volume and stroke volume. It's about 70 milliliters. That is about how many milliliters of blood your heart pumps out with every beat, 70 milliliters of blood. But as your end diastolic volume or your preload increases, your stroke volume increases as well to a maximum here. About 170 milliliters of blood is about the maximum amount of blood your heart will pump out. So if you're delivering more blood to the ventricle, that end diastolic volume is increasing, your stroke volume is going to increase. But then we see here that at some point the opposite happens. As your preload continues to increase, your stroke volume actually starts to decrease. And what the heck is happening there? So at increasing volumes, increasing end diastolic volumes, increasing preload, at some point, increasing preload further actually starts to decrease your stroke volume. And that's when we get into this wonderful Frank Starling mechanism that might be familiar to some of you, not familiar to other people. What Frank Starling is essentially saying is that your cardiac myocytes, that's what this is a diagram of, your cardiac myocytes are kind of these elongated muscle fibers. And when they contract together, and they all contract in unison, and that pumps blood out. Well, the Frank Starling mechanism says that these myocytes, as they continue to stretch, right, because as you fill up your ventricle, they're stretching, which makes sense. If your ventricle is, actually the video might help show this. If your ventricle is small, right, it stretches as it fills, and it stretches those myocytes. And the myocytes, when they get stretched, they actually contract more robustly, more aggressively. And that's what increases the stroke volume in this curve over here, right? As the end diastolic volume, the volume in the ventricle starts to increase, it is stretching your myocytes more because that ventricle is a chamber. It's like a balloon. As you blow up a balloon, it stretches the outside of the balloon. And as it stretches, right, that's supposed to be an arrow, the wall stretching as it's getting filled up with blood. As it stretches, the myocytes, when they actually contract back down and shoot the blood out of the ventricle and pump the blood out, they contract more aggressively, more robustly, the more they're stretched. But that only goes to a certain point, and that's this max here. And after that point, they get stretched so much that they contract less, and the stroke volume starts to increase. So that is essentially the balloon gets blown up so big that it can no longer kind of rebound and collapse and contract back down. And that is when you start to get this decrease in stroke volume. So you can't just keep filling up your ventricle more and more and more and more, and that it'll indefinitely continue to increase your stroke volume. At some point, you filled up that ventricle with blood so much that those myocytes can't contract back down and can't pump the blood out. All right? And it's this, concept of myocardial distension. You're distending the myocardial fibers, the heart muscle fibers, these myocytes, but if they get distended too far, they can no longer contract back down. All right, so increasing preloads, increase stroke volume, as we talked about here, up to a certain point. When you get to that point, that Frank Starling mechanism tells you that you have filled the ventricle too much and the ventricle can't contract anymore. And if those of you that work clinically, this can sometimes happen when someone is fluid overloaded with heart failure. They have so much extra fluid that actually having them pee off fluid, diuresing them, sometimes increases their cardiac output. It increases their stroke volume because you're decongesting that ventricle. You're decreasing the amount of preload delivered to that ventricle. And as such, you're kind of finding yourself in a more appropriate place on this Frank Starling curve. Rather, you might have started here, you diurese off some of the fluids, and you end up in a better spot. All right? There are a bunch of things that affect preload. One is venous volume. That's what we just kind of talked about. So if you're super dehydrated, giving you more volume in your blood vessels, more volume in your veins is going to increase your preload and then increase your stroke volume. In addition to that, as you mentioned, if you have too much volume in your veins, you have heart failure and fluid overloaded, decreasing some of that venous volume can actually increase your stroke volume. Other things that affect preload is ventricular compliance. And this makes sense because not everyone's ventricles are created equal. We talked about this myocardial distension. Well, if you don't have good ventricular compliance, let's say your heart's dilated at baseline, you have a dilated cardiomyopathy. Well, those myocytes aren't going to contract down that well to start with, and your preload might go too high more quickly because you have a low compliance. Atrial kick affects this as well, which makes sense. Let's look at our video again. Right, here's your atrium. They pump blood into the ventricle, and what volume is in the ventricle at the end of diastole is your preload. Well, if you have atrial fibrillation, and if this atrium is not contracting in a synchronized fashion, you don't have a good atrial kick, or this atrium just isn't pumping a lot of blood into the ventricle, that's going to decrease how much blood is in the ventricle. It's going to decrease your ventricular preload. All right. Central venous pressure, CVP, can affect it as well, low and high CVPs. And the duration of your ventricular diastole, which essentially is just how long you are letting the atrium pump blood into the ventricle. If it's too short of an amount of time, your heart rate's so darn high, or you have atrial fibrillation and your atria is just contracting like crazy, you're not going to pump as much blood, so you're going to decrease the preload in the ventricle because the time the atrium spends pumping blood is too short. All right, hopefully that made sense, and that is preload. That's one of the components of stroke volume, right? So there's three main components of stroke volume: preload, afterload, contractility. So we can check preload off the list. Next is going to be afterload. And afterload is a simpler concept. Here's the heart. The ventricle, as we talked about right here, right? This is the ventricle, left ventricle, this is right ventricle, this is right atrium, this is left atrium. The ventricle pumps blood out of the aorta to the rest of the body. Look, they're happy as a clam. This person's getting a great blood flow. But that ventricle has to squeeze against the pressure in the arterial system and across the aortic valve and all that. And that is the afterload. It's the force the ventricle has to pump against. And as one can imagine, as your afterload increases, right, we can see that here, as your afterload increases, your stroke volume decreases because this ventricle is having to pump against higher and higher afterload pressures, and as such it can't pump as much blood out. So your stroke volume actually, as your afterload increases, we'll just write afterload, your stroke volume decreases. And that's unlike preload, right? Preload, we said, as preload increases, your stroke volume increases until you fall off that Frank Starling mechanism, at which point your stroke volume decreases. But initially, increased stroke volume with increased preload. The opposite, increased afterload, decreased stroke volume. We wrote it out here. Higher afterloads decrease stroke volume. There is a small caveat to that, and that's this thing called the Anrep Affect. All right, and the Anrep Affect is actually an effect that's seen, they found in animal models, that says if your afterload in a healthy heart acutely increases, so, let's say for some reason you got scared and your blood pressure skyrockets, and it increases your resistance in your arteries that the heart is pumping against, you don't initially have a huge drop in your cardiac output and, syncopize or something. We're able to equilibrate for that, and that's the Anrep effect. And they actually saw that For healthy hearts, at least to a degree, if you increase your afterload quickly, we'll just say afterload AL, you actually get an increase in contractility of your heart, which we'll talk about next. And that can maintain your cardiac output even though your afterload increased. But in general, we see this effect. As the afterload increases, the stroke volume decreases, with the one caveat being in the acute setting with quick changes in a healthy heart, your heart can compensate for that increased afterload, at least for a certain period of time until it no longer can. But overall, increased afterload decreases stroke volume. And your afterload is affected by, makes sense, the arterial resistance, right? Because your left ventricle is pumping blood into the arteries. So if you have higher arterial resistance, that ventricle is going to have to pump against that. And it's sometimes similar to the mean arterial pressure, your blood pressure, but it is not equivalent to your blood pressure at all. It's more equivalent to your vascular resistance, your SVR. So it's not like, oh, my blood pressure is high, I have high afterload, I need to decrease it. It can relate to that because your vascular resistance is related to your blood pressure, but it's not a one-to-one comparison. It's also, affected by your intrathoracic pressure, how much pressure is in your thoracic cavity, and if there's any ventricular outflow impedance, which essentially in the simplest version would be something like aortic stenosis, because you have, if we go to our video here, you have this is the left ventricle pumping blood through the aortic valve into the aorta. There's a valve here. If this is stenotic, if the opening is small, it's going to lead to the heart having an increased pressure to pump blood through it, and that would be an increased afterload. All right, so let's go back up. We talked about how the stroke volume is determined primarily by three things: the preload, the afterload, last thing is the contractility. And contractility is the actual force that the heart fibers exert when they contract to pump blood out. And again, I put video here because I like this video, but the contractility is how hard these heart fibers are actually squeezing, the actual force of the squeeze that you see happening. That is the contractility. And it makes sense. Any increase in contractility, regardless of the preload, afterload, will increase the cardiac output. If the heart squeezes harder, it doesn't matter what your preload is, what your afterload is, you typically will increase your cardiac output. That is also to a degree as well, though, right? If you don't have any blood in the heart chamber, you have no preload, then increasing that squeeze won't really increase the cardiac output that much, although one could say that it still would a little bit. The thing here, though, that I want people to take away and understand is that the contractility is very much affected by the preload and the afterload. And this is what we pretty much talked about, right? So the preload first, Frank Starling, we'll draw the graph. This is Frank Starling. This is going to be preload on the x-axis, and this is stroke volume. And as we said, as preload increases, stroke volume increases until you stretch those heart fibers too much, and then stroke volume actually starts to decrease as preload increases further. So you kind of have this optimal amount of preload that leads to the highest amount of stroke volume. And once you get past that, once you fall off the Frank Starling curve, your stroke volume decreases. And then we talked about afterload. We said this is, I'm just going to say AL afterload, this is stroke volume. And we said that in general, as the afterload increases, the stroke volume decreases, except with this Anrep effect, which is an acute increase in afterload can actually lead to an increase in contractility to kind of compensate for that in the healthy heart. But the contractility is very much affected by the preload and afterload. Doing things to the preload and afterload can change the contractility, although if you were just to increase the contractility, not a changing preload or afterload, you would increase your cardiac output. And going down here, when we have our kind of purple affected by boxes, contractility is affected by preload and afterload, which we talked about. It is affected by heart rate, which we'll talk about in a second. It's affected by temperature. Those that are hypothermic or have a very low temperature are going to have a decreased contractility. And it's affected by inotropes, and this is something that I think about whenever I'm working clinically. You can give medications, whether it be epinephrine or norepinephrine, which can affect the contractility, or you give true inotropes like dobutamine or milrinone. These are medications you can give through the IV that directly increase the contractility. They do affect preload and afterload, but their goal is to just increase the contractility. So we can give medications that just signal the heart to squeeze harder to increase their contractility. Okay, so if we scroll back up again, we have the 3 things that determine stroke volume. But we talked about that stroke volume is only one half of the equation. The other half is heart rate, right? Cardiac output equals stroke volume times heart rate. And we talked about the 3 things that make up stroke volume. But what about the heart rate? Well, the heart rate is another thing that's fairly straightforward. Defined very simply, the number of times the heart squeezes per minute, also known as the beats per minute or BPM. And if we look at the heart rate and the cardiac output, heart rate here, cardiac output here, as the heart rate increases, the cardiac output's going to increase, right? Because we said cardiac output equals stroke volume times heart rate. But it's important to note that that actually also has a peak effect, after which time there's a decrease in cardiac output, right? We can see here after a certain time, the cardiac output decreases. And can you think about why that might be? Well, if you thought about it, you may have discovered that if the heart is just pumping too fast, there's just not enough time to fill the ventricle. There's not enough time to fill preload, right? Because if we pull up that video one more time, you need time for this atria to contract and pump blood to fill the ventricle. You need time to make up that preload, that end diastolic volume. And if the heart is just contracting 1,000,000 times per minute, you're not going to have enough time in diastole to fill up the ventricle. If we scroll up to preload, remember we said that part of what affects preload, if we scroll up a little more so you can see it all, part of what affects preload is the duration of time in ventricular diastole. So if your heart rate is just going too darn fast, you're going to have much less time in diastole and you won't fill up that ventricle. You will have a decreased preload, which will actually decrease your cardiac output. And clinically, you guys can see this sometimes in things like really bad supraventricular tachycardias, SVTs. If they're beating 250 times per minute, they actually might be hypotensive. They might have a decreased cardiac output because they're not spending enough time in diastole to fill up that ventricle. There is no magic number, no magic heart rate where this happens. Some people you'll read, they say it's like 220 beats per minute minus a patient's age is their quote-unquote kind of max heart rate, but that doesn't really bear out when they do trials, but I guess it is a starting point to have in your mind. So the summary statement here, if we were to tie everything together, we now know that cardiac output equals stroke volume, which is the end diastolic volume minus the end systolic volume in the ventricle, times the heart rate. And we know that the stroke volume is proportional, that's what this sign is, proportional to the preload, which is the amount of actual blood, the volume of blood in the ventricle right before it's going to contract. It's proportional to the afterload, which is the pressure that the heart is actually squeezing against, and the contractility, which is how forcefully that ventricle actually does contract, times the heart rate, which typically as the heart rate gets higher, the cardiac output will increase, but just do remember, as we mentioned, there is a peak effect where faster heart rates don't allow the ventricle enough time to fill and actually will decrease the cardiac output. And then we also talked about how the cardiac index, the CI, equals the cardiac output just divided by your body surface area, so that you know people of different sizes have different cardiac output requirements. Hopefully that was helpful. Hopefully you now feel like you have a fuller understanding of cardiac output, cardiac index, preload, afterload, contractility, Frank Starling mechanism, Anrep Affect, all that good stuff. Let us know what thoughts, comments, questions you have down below, any other topics you'd like us to cover. We appreciate you all. Hope you have a great holiday if you are celebrating. Stay well, keep learning, and we will see you all next time.